Good morning, everyone. My name is Rodrigo Scotini. I'm the Executive Director of the Infectious Disease Alliance. On behalf of our partners and the organizing team, I'm delighted to invite you to our World Health Summit side event, Push, Pull, Partner, building a global AMR incentive ecosystem. So today we are joined by a distinguished group of panelists and on site and online. So the session is being recorded and will also be put online for view afterwards. So antimicrobial resistance is one of the defining health challenges of our century. Despite global recognition of the threat, the pipeline of new antibiotics remains perilously thin, undermined by fragmented policies, unviable market incentives, and insufficient collaboration. To support today's conversation on this topic, we are joined today by our speakers and discussants who will talk about the topic. So you can see here an overview of who's going to be here with us today. So over the next 90 minutes, we're going to explore critical conversation in AMR research and highlight moving from AMR awareness to alignment regarding fragmented response to a coordinated global incentive framework that sustains innovation while ensuring access for all. Behind jumping into this conversation, however, I'd like to provide some big background on the Infectious Disease Alliance and our forthcoming policy paper, Rethinking Antimicrobial Innovation, a policy blueprint for sustainable discovery and development incentives. This blueprint represents the collective work of global experts in policy, economics, and science, and proposes a multi-tiered model that bridges innovation, access gap, while embedding equity and One Health principles in every stage. So this is an article that has been written with some of the partners, some of the speakers here today, and some others that are not here today. We have a preprint version that is accessible, and we are working on the peer reviews with the Infectious Disease Policy Journal. So now I don't want to take much time of you, but I want to briefly introduce IDA, which is a global public health advocacy organization, which is the primary organizer of these events. We are a global health advocacy organization with a vision of reducing the burden, improving access to healthcare, and uniting civil society organizations. So our theory of change is setting priority, and in this case, it's quite clearly AMR incentives is a priority identified. Then we're doing evidence generation, which is basically the article we're developing and in conversation with partners. Then this partnership building, which is happening already, in promoting that piece of evidence through an event and advocacy, which are part of it right now. And then do policy collaboration to advocate for those incentive models that we are speaking about. and finally implementing it through policy collaboration and investment in AMR incentives. So IDA has 12 committees, so you can see that AMR is number 2, but we have several other areas that could be of interest for you and your organizations. Everything is available also on website. So this is the blueprint of the article that I was referring to. You can also scan it and read and even provide feedback when you have time. Otherwise, you could contact our team. We can also send it to you. So this is a part about the results of the paper. You can also scan that one. Sorry, a lot of technology steps here. And without further ado, I'd like to invite the first keynote speaker, Michael Schloter, Director at the Research Unit for Comparative Microbiome Analysis at Helmholtz in Munich. So with that words, it's a pleasure to introduce you, who are going to be speaking about your AMR research within One Health framework that integrates vaccines, diagnostics, microbial science. Yeah. So please, over to you. I don't know if you have a presentation, but here's Yes, you have.
Yeah, thanks a lot. Thanks for inviting me to this really very important event. I think when we talk about AMR, it's on the one hand, of course, having the right drugs in hand. And this is what you guys are doing. You're doing a great job in inventing new drugs, new ways for therapeutics. But of course, on the other hand, we need prevention. And for prevention, the same applies like for new diagnostics and new drugs, we need incentives. And I would like to give you a little glimpse of an idea how prevention could be done, how expensive it might be, and on the other hand, how much costs we can save by doing also prevention. So let me start with a study that we published this year together with colleagues from the UFZ in Leipzig. We investigated the gut microbiome of ancient people living in the pre-industrial age compared to people living nowadays. And we were focusing on the presence of antimicrobial resistant genes. And here you can see the ancient people, and you can fairly see that there is no antibiotic resistance occurring 200 years ago. Now, when we move to people living nowadays, you can easily see, depending on their diet, the amount of antimicrobial resistant genes in their gut is significantly increased. And you can also see that depending on the diet, the frequency and the abundance of these genes is very much differing. You can, for example, see when you eat more meat, you have more antimicrobial resistant genes in your gut microbiome compared to when you only eat as a vegetarian or as a vegan. So the first take-home message is, and I think this does not cost anything, think about your diet, because your diet strongly influences the abundance of antimicrobial resistant genes in your gut. And this is, of course, a very, very important risk factor, because when you consider that these genes can be transferred to pathogens, once the selective pressure is increasing by giving antibiotics, then it is obvious the more genes you have of this kind, the more risky it is that these genes are transferred to pathogens which then become resistant. But why is this the case that we have this very strong increase in antimicrobial resistant genes? And this is a study we did with Klebsiella, which is one of the most important, let's say, escape organisms, which is also highly triggered by antimicrobial resistances. And of course, we have two sources. And this is the wastewater, not only coming from clinics, but also coming from households. And it's the animals and it's the manure. And the manure is applied without any further treatment to the field. And also the wastewater is not very well treated in terms of antibiotics. So what happens is that all these antibiotics come to the environment, they accumulate in the environment, and when they accumulate, there is a strong selective pressure that there is an increase in antimicrobial resistances. And you can nicely see on the bottom that indeed the amount of antimicrobial resistant Klebsiella increased in the last 50 years significantly, and it's not only the amount, it's this issue of multi-resistance, which become very prominent. You can see in the 70s it was only one antibiotic where Klebsiella was resistant to. Nowadays it's 5 or 6 antibiotics what Klebsiella is resistant. So it is very important that this issue of multi-resistance is becoming more and more important. And why is this the case? Antibiotics are natural products, most of the antibiotics. So during evolution, they were triggered in a way to have very long half-times. So it is efficient for an organism when they produce these antibiotics, and they are very long-lasting and very long-active. And this is indeed what happens with most of the antibiotics, mainly the sulfonamides. You can see they have very long half-times in natural environments, up to 20 days. And this means, of course, that there is this very, very strong selective pressure present in the environment, and this induces then the spread of antimicrobial resistant genes. And you can see that this is not only a topic which is somewhere happening in rural environments and somewhere in some wired water systems, it really reaches the cities. You can see here a large number of cities where people were measuring antimicrobial resistant genes in the environment of the people living there. And you can see a very, very strong increase of antimicrobial resistant genes in urban environments. This is partly related to the fact that I was explaining that there is no treatment of the wastewaters and there is this manure issue, but there's also co-selection with other urbanized polluted factors, which induces this high abundance of antimicrobial resistant genes in urban environments. And when you think about that, it becomes obvious that people nowadays are really highly affected by these antimicrobial resistant genes, which then explains also partly this high abundance that we were measuring in the gut system. So, but what can we do? And one of the things what we are thinking will be very promising, at least when we talk about this classical antibiotics, is beating the microbes with their own weapons. Because some of these microbes developed strategies which are able to degrade these antibiotics in the environment. And this is, of course, a great thing, because when we have these enzymes in hand which can degrade the antibiotics in an environment, we can naturally reduce the selective pressure which is present in the environment, subsequently leading to the fact that there is not so much spread of antimicrobial resistant genes. And one of the topics that we are working with is this degradation of tetracyclines. There is a so-called enzyme which we detected is a destructase, and we could show that with this destructase, the tetracycline is efficiently degraded, and we are now trying to implement this approach in wastewater treatment plants to get rid of the antibiotics in the wastewater treatment plants so the effluent will not reach the water bodies and the subsequent environment, so reducing the selective pressure by this particular degradation in the wastewater treatment plants. Of course, what we have to do is monitoring. And I think the most important thing is that we know which are the emerging antimicrobial resistant genes coming up, not only single genes, but also this issue of multi-resistance. So I think it is very important that together with this monitoring that has been now implemented for viruses in the wastewater treatment plants, we are also implementing a monitoring system for antimicrobial resistant genes. And this should not only be just qPCR by looking if these genes are present, it should be non-targeted to detect also new antimicrobial resistances, but also multi-resistances. And again, this is something, of course, which costs money. And this is why these things are hard to discuss with the politicians to implement that, because it is really expensive when you do this on a really frequent basis. And of course, a last thing which I think is very important, we have to simply improve the health. And not only the health of the humans, but also the health of the animals. For example, this is one example where we are working with, it's aquaculture, and aquaculture systems are really like monoculture systems. And they induce a lot of problems for the fish, a lot of infectious diseases. So when you could reduce this burden for infectious diseases by changing this multiculture system in a, let's say, multi-trophic ecosystem, where there are a lot of benefits also for the fish, automatically you can reduce also the amount of antibiotics that needs to be implemented. On the other hand, you can also implement, for example, probiotic bacteria just to avoid that the fish get sick and that antibiotics have to be applied. So this is the third point. It's the point of monitoring, it's the point of improving health, and it's also the point of degradation of these particular antibiotics in the environment. And when we take this into consideration, I think we have a very good toolbox in hand for prevention, together, of course, with the development of the new drugs, which is ongoing. So with this, I'm through with my presentation. I hope I can convince you that prevention is at least also important together with the development of new drugs, and also their incentive and the discussion about incentives becomes very important in the future to implement these strategies that I was showing you. Thanks for your attention and happy to answer any questions.
So thank you, Michael. Now I will give the floor to the next. Maybe let's take a question if you have any. This is a good point. Does someone here on the floor or in the online has any question regarding his presentation or any comment? The panelists can discuss it during the panel session. Simone, yeah.
Very good point about, of course, the cost of implementing certain measures, and of course this is very important for local, national politicians, if you do a local, strategic level, national level, etc. But it's also important to highlight, to stress on the cost of non-action as well. So I don't know if there's any evidence that you can share, but I think this is an important point, not only stress, but on the difficulty of applying certain solutions.
You're totally right. Socioeconomic costs increase far more than the direct costs, which needs to be given for the implementation. However, the socioeconomic costs might emerge in 10 or 15 years. The costs that you have to apply are right now. And this is, I think, the big issue, that in many cases, politicians just think about 5 or 6 years periods. But we are talking now about a period of 15 to 20 years. And when we think about what the WHO prognosticates that in 2050, which is 25 years from now, most people will die of infectious diseases, then somehow this problem was turned back, because there is now a lot of other emerging problems. And most likely people will open this box maybe at a time point when it's too late.
Can definitely continue this conversation in the panel. Thank you, Michel. Right now, I'd like to invite our next speaker, which is the one who just asked the questions, Simone Mancini from the Global Sepsis Alliance, who's going to be speaking on sepsis, the face of AMR, synergies and paradoxes of a common fight. So the floor is yours, Simone.
Thank you. Good morning, everyone. Little disclaimer, I'm not a scientist, I don't have a medical background, so please, apologies in advance for any inaccuracy. But my objective today is a bit to crash the party, in the sense that we're talking about AMR, and but what happens often in a discourse about AMR infectious diseases is that we miss bits. So I think it's important. I think we share this vision with the Infectious Disease Alliance. I think it's important we're talking about infectious diseases to really look at the whole spectrum of the problems, and therefore synergize the engagement, synergize also the solution. So let me have a little introduction about the Global Sepsis Alliance, which is an organization founded a bit more than 10 years ago. 15 for that matter, by Professor Konrad Reinhardt, who was here yesterday discussing NCDs. The Global Sepsis Alliance is the founder of the World Sepsis Congress, which is an online congress happening every year, attracting yearly average of about 12,000 online attendees. And we're also the initiator of the World Sepsis movement since 2012. And one of the, what you see here is the team. It's a small team, but actually we're supported by a fantastic expert around the world. One of the milestones of they were very proud of is this sepsis resolution adopted by the World Health Assembly in 2017. And in fact, the World Sepsis, this sepsis resolution exhorts member states to integrate sepsis in their health systems, also within their national AMR plans. And I think this bit is still missing. This resolution hasn't been picked up yet fully, but we will look into this. We are, of course, as I said, we have a global outreach, and we do this via working with our regional alliances, mirroring the WHO regional WHO regions. So I'm sharing no news, but this was issued yesterday by the WHO. It's the new report on antimicrobial resistance, and I think it's important to highlight certain points that actually were already stressed by Professor Schloter. The problem is enormous, it's increasing, and it's under the eyes of everyone. The report confirms that 1 in 6 infections actually are resistant to antibiotic treatment. There's been a steep increase in resistance from 2018. Of course, the most affected region, not unexpectedly, are the South Asian region, it's the Mediterranean region, but also the African region with 1 in 5 infections. As Professor Schloter mentioned, Klebsiella, E. coli are the leading drug-resistant bacteria that are found in bloodstream infections, and these actually, what this says, often lead to sepsis. So these are the main actually pathogens leading to sepsis. So you can see here already that the problems are intertwined. And what is interesting actually is these impressive figures that like 40%, 55% of E. coli and Klebsiella infections are resistant to the first choice treatment. And in the African region, this resistance exceeds 70%. So the problem is massive. This is other figures coming from, this has not been published yet, but it's been shared at the side event that we organized in New York, at the UNGA side event in September. What you can see here, these are figures from the Institute of Health Metric and Evaluation, will be published likely in November on the Lancet. And what you can see there is that basically what this map says is that respiratory infections actually are the main cause of death amongst the top 30 pathogens amongst all infections, all genders. So, and these are actually the pathogens that most often lead to sepsis. And this is exactly the pathogens, Escherichia coli, Klebsiella, which were highlighted also in the AMR report. So this is again to stress on the relevance of AMR for sepsis. Now, this was also published on Sunday. The new global burden of disease data, as we have seen yesterday, after the COVID peak, NCDs have climbed up the rank of leading causes of death in 2021. But as you can see again, after heart disease, stroke, and COPD, respiratory infections are, I mean, the top infectious diseases cause of death among infectious diseases. So now, what's been our response to this situation? Last year, at the European and the German Parliament, we launched the 2030 Global Agenda for Sepsis, which is the first global strategy on sepsis, trying to really look at the whole spectrum of the problem, highlighting the current status quo, current evidence, and proposing solutions. This was elaborated with the major global health stakeholders. As you can see, in collaboration, of course, with our regional alliance, we also had the technical support of WHO staff. Now, this is where we were starting from. These are the data from the 2020 Global Burden of Disease study on sepsis, that highlight really the massive burden of this deadly condition. And of course, as you can see, most of the burden happens in low and middle income countries, and affects especially certain population, including children under 5. And according to this data, basically at the time, 1 in 5 deaths actually worldwide are associated with sepsis. Now, starting with these pictures, we can already identify a couple of paradoxes. As we seen the importance of antimicrobial treatment in sepsis, of course, is clear to everyone. That's the first response to sepsis. But what we notice, despite the impact, and I'm going to show you actually also more striking figures, is the discrepancy between the burden, the evidence, and actually the political focus and on the solutions. And secondly, is what we see is that the response from countries, actually, most of the response happens in high-income countries, while, as we see, 85% of the burden is in low and middle income countries. So there are definitely issues here that must be fixed. Now, in relation to AMR, you can see basically why we say, I said at the beginning, AMR is the face of sepsis is the face of AMR, because in fact, actually, what happens if you cannot treat an infection? Actually, you and the infections become actually very dangerous and develops into sepsis. And sepsis shock, most likely you're going to die, of course, of sepsis. You don't die of AMR, in fact. So, and I think it is important to keep in mind, because then if you want to solve the resistance problems, actually, in parallel, we need to look at, okay, what happens when resistance happens? And how do we solve that? So, as I was saying, the response actually and the attention between these two problems actually is not balanced. It's definitely not proportional to the problem we are talking about. These are the data from the Institute of Health Metric and Evaluation and these are 2021 estimates. So estimates based on 2021 data. We're talking about more than 21 million deaths from sepsis annually, compared to the 4.7 resistant associated. And this a bit reflects the proportion of the WHO AMR report identified in 1 in 6 infections broadly being resistant. There's also the one example, of course, we're engaging with policymakers, and some are picking up, of course, understanding the importance of sepsis response, and although mostly in Europe, unfortunately, and not unfortunately, but only. This is the Minister of Health of Belgium quoting actually our CEO in this quote that I mentioned before, that sepsis is the face of AMR. This is some of the countries actually that have initiated some sepsis response, mostly with the sepsis plan, or somehow with initiatives that actually been rolled out. This is just another interesting quote from Jeremy Farrar, as one of our congresses, that of course stresses how sepsis can be like a proxy of the preparedness of a health system, as because of this horizontal nature that can happen actually, and we saw that yesterday also with discussion on NCD, sepsis can happen in every different stages of the care spectrum, let's say. So this is a couple of, just to highlight a couple of tools that we have identified in our 2030 strategy, and of course, our focus, of course, is to put patient survivors and their relatives at the center of our advocacy work. We have launched a Global Sepsis Survivor Family Committee this spring, and this is, of course, growing very much as a growing interest. And also another interesting platform that I would like to highlight is the Global Sepsis Innovation Platform, where we really we will break down the discussion, the analysis of the sepsis problem into different pillars, and we're having working groups that will look into advocacy, policy, regulation, innovation, research, etc. So please, should you be interested in joining this discussion, be part of the solution, contact us. And of course, as I say, advocacy is very key in our skill element of our work. As I stressed before, awareness is key. We are still in the phase we really need to engage with policymakers. We need to engage. We need that policy engagement, and then we lead to solutions. And this is just only the recent examples of engagement we had around World Sepsis Day, which happens every year on 13th of September. We were in New York in September. Of course, I'm very much engaged here around World Health Summit. So with this, I want to thank you for this opportunity to bring in this additional element to the discussion, and happy to take questions. And I really invite you to engage with us. And thank you for the attention. Thank you.
Any questions from the public so far? Your presentation was
very good. Perfect.
Perfect. Then we're going to move to the next part, which is the roundtable discussion. Some of the guest panelists will be online, some will be here in person. So I'd like to invite one by one to join the roundtable discussion called Incentivizing Innovation Strategies to Combat Antimicrobial Resistance and Revitalize Antibiotic Development. So the first guest speaker will be Dr. Adnan Ganci, Senior Program Director from AMR. If you'd like to take the floor. The next one I'd like to invite is Eric Venant, which is a founder of Rollback Antimicrobial Resistance Initiative. Then online we have Rohit Malpani, Senior Advisor at GARDP. Yes, hi. Then the next one will be Professor Michael Schloter, who spoke before, Director at Research Unit for Comparative Microbiome Analysis at the Helmholtz Munich. Okay, so in that case, I'm sorry, almost forgetting, Wendla, Antonia Bayer, Global Affairs Lobby and Advocacy Specialist at 4Pulse. Yes, feel free to take a seat. So our discussion today is guided by 3 questions. So, how can innovation, regulation, and funding models be aligned to overcome barriers in antibiotic discovery and development? Second, what collaborative and equitable approaches across public, private, and global partners are needed to strengthen stewardship, access, and awareness? And third, how can diagnosis, data, and education accelerate effective antibiotic use and ensure that innovation translates into real-world health impacts? Now, to answer this question, we'll move to the first question to our discussants. That will be Dr. Ganci. So, Dr. Ganci, what do you see as the biggest obstacles we face in introducing new antibiotics today?
Thank you very much. Thank you, everyone, for having me here today. Thank you, Michael, for a really good talk and a really interesting talk on surveillance and the changes we need within the ecosystem. I was at the European launch of the One Health AMR research initiative last week, and I'm sure there'll be lots of funding hopefully coming your way for that kind of research. And I'm really interested to talk to you afterwards about the enzyme stuff, actually. And for your talk as well, Simone, I'm a clinical doctor by background. I work in the emergency department, and sepsis has been drilled into me since day one. And I think that's a change from from the previous generation of doctors. And I'm sure that will continue. So can you just repeat the question for me?
So what do you see as the biggest obstacles we face in introducing new antibiotics?
Yes. So we've not. So the title of the discussion says push, pull, and something else. But the push and the pull we've not really discussed today yet. Developing new antibiotics is really, really hard. Failure rates are astronomical. Failure rates are high in pharma generally, anyway. The business case is pretty terrible for antibiotics. You spend $500 million to develop a drug, and nobody wants it on the other end. There's not a guarantee that you'll have a good income afterwards. The pharma companies, mainly most of the big ones, have exited from the antibiotic space. They have to compete with really low-cost generics. We've got a graveyard of developers and pharma companies that have tried and all gone bust in the past. And the bulk of antimicrobial resistance is in low-income countries that can't afford a lot of these drugs or pay for the development of a lot of these drugs. And this is where people like Rohit at GodP and Carbex are doing really good work with something called push funding. For those of you who don't know, push funding comes early in the life cycle through milestones and grants and picking people to fund who are looking promising within the ecosystem and making sure that they can continue despite this market failure. The other part of that, the solution is something called pull funding. So pull funding is the idea that if a developer or a pharmaceutical company develops an antibiotic that has the characteristics that we would like, they are given money for that case. The traditional or the poster child for pull funding at the moment is the UK's subscription model, which they call a Netflix subscription model. Some of you guys might know, because everybody likes putting a tech word inside of a little buzzword these days. And the idea is if they produce a product, an antibiotic with the criteria that hits the bacteria that we want, they guarantee the pharma companies that they will buy this drug for the next 10 years, regardless of how much they use. So to answer your question, the big problem is it's really hard to develop a new antibiotic. And the other thing is the market incentives really aren't very good. So that's why we need a combination of this push and this pull. And at the moment, the world globally is far, far off putting the amount of money that's needed to incentivize development, both at the push side and completely at the pull side. So that's the policy angle that we work on.
Thanks. That has been a very good introduction to the topic, and I think no better partner to go into the pool and push incentives than AMR. So as the next panelist, I'd like to speak to Professor Schloter. So in light of the current innovations like AI, how can we secure the necessary funding for promising strategies?
Yeah, I think on the one hand, coming back to what you said about low-income countries, I think one of the major reasons why we find this high increase of AMR in low-income countries is wastewater irrigation. What they are frequently using, where they put directly the wastewater, independent it comes from private households or from clinics, to the field. And this is a really very big problem because you increase the selective pressure and you increase the amount of AMR significantly. And this, of course, pays back then to the pathogens and to the humans. So I think in addition to what you said, this is a problem we should have in mind. And I think what we need is databases where all this data about antimicrobial resistances, about multi-resistances, about also the organisms which carry these resistances, because this is important, because then we can predict what pathogens might be affected by a new emerging antimicrobial resistance. So we need these databases on a more or less global level to ensure what comes next. And I think to figure out then what are really the priorities, this is exactly what AI can do. And there are some very, very local databases where people did this very locally, but people, I think, did not understand, despite we had Corona, that things happen anywhere on this globe will feed back to Europe. It's just a matter of time. So having these global databases, and this, of course, costs money. And of course, this must be associated somewhere to WHO or wherever, where all this data feeds in. And then we have good tools, let's say, also for predicting what comes next. Because I think this is very important also for the clinicians, that they know what will happen in the future. And I think there we have to convince people far more, not only on this very local level where we can somehow interact with the governments, but this needs to be something which needs to be discussed, I think, on a very, very global level, because this is the only level where this topic, I think, can be efficiently addressed.
Yeah, that's very, very good point. Thank you, Michael. So for next one, I would like to work on digital inclusion with Rohit Malpani. Thanks for joining us online. So GuardP is obviously a public-private partnership, and I would like to ask you two questions. So what can be the role of public-private partnerships in tackling antimicrobial resistance? So a very general question, existential question a little bit about GuardP. And if you can complement a little bit on what can we do to secure necessary funding for promising strategies? So a little bit maybe the point that Ganchi was saying about push and pull. So if you can link the two, it would be great.
Sure, thanks a lot. Thank you for inviting, and sorry I couldn't be there in person. So just to start, GuardP is not exactly a public-private partnership as much as it's a not-for-profit partnership that works with the private, public, and not-for-profit sectors to be able to develop and accelerate access to antibiotics for all people in need. And I mention that just because even though obviously we put working with the private sector at the center of our strategy, there can be differences in terms of sort of the objectives, the mission, and the outcome, where I think some of GuardP's work may involve sort of very light touch relationships with the private sector, but are entirely focused on sort of public health failures and public health needs that may or may not really touch on commercial priorities or anything that the private sector is focused upon. So for example, funding and development of new combinations for neonatal sepsis, which is one of the leading causes of death due to drug-resistant infections. But to come to your question, I think obviously public-private partnerships and not-for-profit partnerships sort of, especially over the last decade, have really started to play an indispensable role in how we develop and ensure access to antibiotics. And I think you can think about that both in terms of the specific projects that really are sort of set off in one direction to develop new antibiotics, and then just the wider ecosystem in which we're working in. And I think that cuts across some, really on an end-to-end basis. So when you think about the funding of research and development, what we have today is really a mixed environment, both in terms of public, philanthropic, and then also private funding of research and development, including also organizations that are mixing a lot of this sort of public, private, and philanthropic funding to be able to support research and development. And obviously GuardP and also CARB-X are examples of that. When you think about discovery and preclinical work, you have this sort of handing off of where a lot of the discovery and the basic science is really done now by academia and research institutes, and then is handed off to usually small companies that are then trying to turn that into preclinical work and translational discovery. You also have some examples of partnerships. So for example, GuardP is currently working with DeepMind in order to use artificial intelligence to identify and potentially design new compounds. And then again, as you work through clinical and pharmaceutical development, you again have a mixed environment in which you have obviously companies that are trying to complete clinical development in places that they traditionally have worked in, but they also are in partnership with not-for-profits to be able to conduct clinical development also in places that have a high burden and a high need for new antibiotics. So for example, GuardP is now in the process of completing a partnership with Innoviva Specialty Therapeutics, which was previously Entasis, for the development of zoliflodacin, in which GARDP led the phase 3 clinical trial in some high-burden countries, including South Africa and Thailand. And then finally, when we think about access, this is obviously something that's very challenging for companies to do, especially the smaller ones. And this is where partnerships, again, play an important role. So, for example, with GARDP, which has signed a license agreement with Shionogi to be able to expand access to cefiderocol in 135 countries. And that also includes a sub-license with an Indian generics company in order to expand access. And again, I think that the importance of all of this is especially because we are in an environment in which funding is, really facing a historic retrenchment, in which we're seeing not only diminishment in the amount of funding being provided by traditional donors, but also a debt crisis in low middle income countries to both pay for research and development and to ensure access. So I think we really have to be able to create these sort of, again, partnerships and ecosystems in order to ensure that we can create opportunities for funding. I think we also have to be careful in how we define pull incentives. If we try to have pull incentives try to replicate the current pharmaceutical market, it's not going to succeed. We now have revenues for new blockbusters that are coming out that are exceeding, multiples of $1 billion per year when you think about immunotherapies and GLP-1s. So we really have to think carefully about designing pull incentives that are targeted towards supporting small and medium companies that really don't otherwise have an exit strategy to bring new products to market and not simply trying to replicate blockbuster revenues. Thanks.
On my side, why do you think it's more likely that small and middle-sized companies can develop antimicrobial instead of large companies?
The simple answer, was that directed to me? I'm sorry, because you cut off at first. That was directed to me, I assume. Sorry.
Yeah.
Okay. Well, I think there's a few reasons. The first is that there's been a significant amount of investment into small and medium enterprises, especially through Carbex and also through BARDA and a few other entities. And this occurred at the time in which I think there was a lot of sort of global consensus around needing to revitalize the antibiotic pipeline. There's also just simply the opportunity cost for larger companies, again, because a lot of the commercially attractive areas are so lucrative now compared to what can be earned in the antibiotic market, even including pull incentives, that it really doesn't make sense for the largest companies to be able to invest in research and development. Now, I think there's some nuance in this also. The first being that there are some larger companies that continue to invest in antibiotic development that have had a sort of history of doing so, and we can think of GlaxoSmithKline, or that are companies that are privately owned, such as Roche, which have had a long-term commitment towards developing new antibiotics through their sort of family ownership structure and want to continue to do so. There also is a large category of medium-sized companies which have a commitment towards developing antibiotics and that have a product mix that allow them to defray some of the risks, but also sort of don't see necessarily as high of an opportunity cost. And then I think that what we need to be discussing more is also just the number of new companies in India that are both developing new antibiotics and also have a healthy pipeline. And I think that also presents a different value proposition because their costs are much lower, and also the populations that they're targeting are the ones that often are facing the highest burden of resistance. And so I think we also have to be thinking more broadly about which companies can develop new antibiotics and not just what we've thought about over the last decade.
Thank you. I think there's some very interesting points. I will come back to this topic. I think it's a key one for this discussion today. So now I would like to move a little bit to other perspective and bringing now Vendla Antonia Baia to the discussion, because I think there's always two sides of the story. Of course, you have the development of drugs, but we also have to avoid and prevent infections. And I think you have been very vocal in this space that preventing infections between humans and animals, it's a key point. So we'd like to hear a little bit on your health approach and how ForPulse acts in this area.
Thank you. And thank you so much for inviting the animal health, animal welfare perspective into this conversation. I was so glad to hear your presentation, Doctor, because I'm always happy when I'm not the first person on a panel who points out, unless we look at the way we farm animals, we're going to be in big trouble when it comes to the environment. Sorry for being so blunt. I'm probably the only person on the panel not having a PhD, so That's why I need to say it bluntly. And we, for example, we very often come across the issue of antibiotic stewardship in agriculture. And again, put very bluntly, stewardship is essentially using antibiotics correctly and using them only when they are absolutely necessary. And in agriculture, that means use antibiotics only when animals are ill. But what do we do when animals, on a massive scale, are systematically ill and antibiotics are routinely needed to treat them? We reduce the incidence of infectious diseases. That's the solution. We turn to prevention. And sometimes I'm just sounding dramatic, animals being systematically ill, antibiotics being used routinely. But the truth is that in intensive commercial production systems, that's pretty much the reality. Animals are kept in conditions that subject them to acute and chronic stress conditions, such as being unable to express natural behavior, not having access to outdoor natural environments, being overcrowded. And all these conditions, they subject them to continuous stress, which leads to suppressed immunity, which leaves the animals more susceptible to infectious diseases. We have a prevalence in infections, and we need to treat them with antibiotics. That is the cycle. So what's happening actually in our food production systems is that, in essence, antibiotics are being used simply to compensate for inadequate keeping conditions of animals. And that's, of course, not good antibiotic stewardship. And that's why at 4PAWS we keep turning everyone's attention towards prevention and the need to prevent infectious diseases in our farming systems by addressing the contributing and predisposing factors for infectious diseases and essentially fixing the contributing and predisposing factors for infectious diseases. That's just a very fancy way of saying improving animal welfare, ensuring good animal welfare in farming. And I want to turn again to your presentation because you mentioned at one point aquaculture, and there are, I have an example in Egypt, sorry, I always forget the what was it? Tilapia, thank you. We don't work on fish, but I think it's a great example, and I always stumble upon the name of those. In tilapia, for example, aquaculture, training of farmers on animal welfare was identified as being one of the key interventions that improved animal welfare and reduced actually the use of antibiotics. But we have more examples in such areas. In the Netherlands, using slower growing poultry breeds and reducing stocking densities has reduced antimicrobial use in poultry farms. In pigs in Denmark, we've seen how separating piglets at a later age from their mothers and allowing them outdoor access has the need for antibiotics for gastrointestinal diseases, particularly post-weaning diarrhea, which is a huge issue in pig production. So we're actually seeing real-life examples, and I have a bunch more of those, but I don't want to bore everyone. We're seeing how simple improvements to animal welfare are actually contributing to improving animal health, to preventing infectious diseases, and they're effectively reducing the use of antibiotics. And that's what we're advocating for. That's why we're bringing, as 4PAWS, we're bringing the animal welfare issue, the prevention issue into the AMR conversation. And over the past years, we've noticed it was a lonely journey in the beginning. It wasn't so long ago that we started out, 3 years ago. But meanwhile, we're noticing how key stakeholders from international organizations to the global governance structure on AMR, they're talking more and more about this issue, and they're slowly recognizing it as a pillar of infection prevention in agriculture. Thank you.
Maybe I can add on this because this is something where we are really working hard on it, and it's the big issue is to convince public about the benefits, because at the end they have to pay more for food, and this is of course what people don't like to do. But you have to see that in addition to the issue of antimicrobial resistances, I think there's another point. It increases the quality of the food. When you have a cow on a grassland with high biodiversity, it produces milk of a far better quality. It has fatty acids, which are really beneficial for the humans. And I think this is something how we can get public on board, saying that milk is not milk, that meat is not meat, and fish is not fish, but it's the quality. And depending on the quality, it enhances also our health. So there is a second line of benefits beyond having less amounts of antibiotic being applied. It has also the quality issue, where I think we can easily get the public better on board than it is at the moment.
Very interesting point, and maybe thinking of the tax elements of course, if you're importing cheaper meat that is being produced with lower quality, lower levels of stewardship, is it maybe an occasion to increase taxes so that local production with better stewardship, or in places with better stewardship, can compete in the market in that way, benefiting everyone and reducing AMR resistance?
Just to address this, I think having a bottom-up approach is always better than having a top-down approach.
Yeah.
Increasing taxes is a typical top-down approach. Convincing people that there is a benefit is a bottom-up approach. So I think working on this really issue of taking people on board and convincing them is far more important, and we had this in many different other areas, like increasing prices for fuel and whatever, where people are not taken on board. I think we should learn from these mistakes and taking people far more on board from the very beginning, and I think we have the best arguments in hand.
Maybe we end up with a low antibiotic certificate for meat in the future. Who knows?
That's actually more tricky than you'd think, because just using reducing the use of antibiotics without fixing the issues that cause infectious diseases can actually lead to increased morbidity and mortality in herds, and it can cause losses to customers, to farmers. So that's why we need both ends of this story, and that's why I'm so glad that you mentioned also the bottom-up approach and the support that needs to be provided on a community level to farmers, and to plan and implement infection prevention strategies that include animal welfare in manners that are always adapted to local realities and to the realities of the production systems, because we have such different needs and such different priorities for animal welfare, for example, whether we're talking about global north or global south, large scale or small scale, pastoralism or something else. We need to look at different things, and there needs to be this really bottom-up support to improve farm animal welfare, to improve prevention, because this is also what reduces morbidity, reduces mortality, improves the resilience of food systems, and brings also co-benefits for the farmers and the communities who depend on them, especially in smallhold farmer settings.
It's a very good one. Thank you, Vendela. I will move on to the last speaker. I was waiting patiently for the question. So, Eric Vendent, how to roll back on antibiotic resistance, and what can be done to better address the current AMR crisis? So a very general question. So maybe you can present a little bit of your work.
Yeah, thanks so much for having me, and also thanks so much for bringing issues around antibiotic stewardship as well as the bottom-up interventions. And it's really interesting discussions on how we can bring communities and foster the public engagement. And I think that's one of the key priorities on how we can engage the communities to sustain positive behavior change. And I think we really need a whole of society approach. Based on our work and experience, we have been approaching this with an intergenerational aspect by engaging the community members, engaging the children, engaging the youth to advocate for best practices at the family level, as well as engaging the community members and community leaders to support the adoption of these best practices. But then we really need to go beyond the traditional approaches when it comes to the public engagement, and we really need to embed behavioral science to ensure that there is sustained behavioral change at the bottom level, taking an holistic approach. Then I would also like to highlight on how this could be successful, especially now where there is challenges around financing of national action plans on antimicrobial resistance. And it's very crucial to leverage the existing systems on this. In September, the WHO released the technical guide on how to engage community healthcare workers in antimicrobial resistance. So these have been very critical, for example, in addressing other health challenges like TB, malaria, child and maternal health. So as well as to foster antibiotic stewardship, it's very critical to leverage these existing systems to make sure that we integrate antimicrobial resistance, especially with a challenge in funding. Then it's very good that One Health has been brought during the keynote address, as well as with previous speakers. But we really need the human-centered connection, bringing the patient stories to give AMR its human face, and then be able to foster behavioral change. So I would like to emphasize from that angle of a whole of society approach with behavioral science at the center. Yeah.
Good point. And I appreciate your intervention. I have some questions here, and we still have a half an hour. I think I would like to talk a little bit about, before moving back to pull and push incentives, and I think the article we have been focusing on has been, of course, talking about incentives, but not forgetting the stewardship, because there's no use of new antimicrobials that are going to come back to reality and develop quickly resistance. So I think that point it's been very, very key. Now I want to talk a little bit about diagnosis. There's no specific person. Feel free to raise your voice when you want to touch it, and also the public. Looking here at the Club of Sepsis Alliance, if you would like to talk a little bit about diagnosis, if you feel comfortable. So what steps can be taken to optimize diagnostic tools to support effective antibiotic use? Talking about point of care, general diagnosis. Is someone comfortable to start telling a little bit about what you think of the importance of diagnosis in this process? Yeah, open to the floor. No, we can. Yeah.
Yes. So I think it's very important to ensure you have affordable diagnosis, and this is very critical for prudent use and judicial use of antibiotics, not only for prescribers, but also from my perspective of communities. But how are we making diagnostic accessible? And this has been a challenge, but we can take some of the successful models and examples, for example, in malaria, where there's been innovation around the rapid diagnostic test. But how could we leverage that also in other diseases and other challenges to make sure that there is equitable access of diagnostics, but also affordability around the diagnosis. Yeah.
Yeah, I think on the first glance, it's important to discuss what we expect from diagnostics. Do we just expect there is a certain antibiotic resistance present or not present? Or do we expect more? Do we want to understand multi-resistances? Do we want to understand which organisms carry the resistance? And at the moment, the diagnostic that is done is mostly done on a very, very low diagnostic level. So people are doing qPCR, and then they see if there is a certain gene available or not. So I think on the long term, this will not help. We definitely need more sophisticated tools where we can really say this is multi-resistance or not, where we can identify the particular host. And I think seeing the progress that has been made now in all these molecular tools, like you can have now your small sequencer put to your particular laptop and you can sequence wherever you are. So this was a dream, let's say 15 years ago. Now everybody can do it and it becomes affordable. I think we have to bring this also to the people to say that these tools are available. And looking, for example, what happens in the Netherlands, where people going to the hospital, there's a diagnostic if they carry multi-resistant bacteria or not, and if they carry, they come to a specific place at the hospital to avoid that there's a cross-transfer of these organisms to the other patients. So this is a very, very perfect example, and it works pretty well. And the costs are indeed not as high, but I think this needs to be transferred to the people, and I think this is a joint effort of all of us, not only of the scientists, but also of the other people working in that field, to show that these tools are now affordable and they give a very, very big benefit compared to a simple monitoring of just particular genes that we already know.
Just to jump in, sorry.
Oh, go on, Rohit.
Thanks. So just quickly, this is something that, you know, as an organization that is focused on accelerating access to antibiotics, we recognize is a major gap. So one thing that GARDP has done is working with other organizations to launch just a few months ago something known as the AMR Collaborative, which is intended to be a global platform to really deal with, you know, all these different failures we're seeing right now in the diagnostic space with respect to access and effective use of diagnostic tools. And this is involves a series of different partners, but it is trying to work around 5 priority areas. So innovation and evidence generation, so essentially identifying fit-for-purpose tools, especially for low and middle-income countries, to be able to focus on access and market shaping, to look at the broader ecosystems of policy and economics. So how do you ensure that, you know, these diagnostics sort of have the right sort of business case for getting integrated into national action plans and health budgets, how to construct the right country capacity, and how to think through regulation and governance. And so this is still very much at the front end. It is being sponsored by the Fleming Initiative, and it is coordinated by a couple of institutions based in Ghana. But, you know, we think it's important to surface all of these questions and to really be able to find ways forward on this, because otherwise all the advances hopefully we'll make around treatments won't really be that meaningful.
Thank you. With my clinician hat on, super duper important. There's lots of talk about diagnostics, lots of talk within coming EU legislation about how to incentivize and procure the right kind of diagnostics, and it really fits with the innovation strategy that the EU is trying to lean on. Within my clinical practice, post-COVID, there was a real shift, and everybody felt that with everybody at home using point-of-care testing, which had some uses and some problems. So having the right sensitivity and specificity in terms of testing and knowing, is this is this a point of care test or is this a diagnostic for a clinician? Is it for the health system? Is it for surveillance? They're all important questions, and being able to model the economic impacts of that and whether a country or a lower middle income country should invest in that is quite difficult, but it's work that needs to be done. And I'm sure with the One Health initiative, more money will be going into that. Yeah, the other thing to say is adequate prescribing is done poorly in lots of countries already. Adding an extra layer of cost, which is the diagnostic itself, is difficult because you're asking both the person who's buying the treatment to pay more for the treatment. So where is the money going to come from to add that extra layer of decision making? I don't know. And I think a lot can be done just at a very simple level of training healthcare workers to do better and having good surveillance systems and auditing systems for that to happen as well. And all these things will happen in conjunction with each other, I'm sure, because this is a really multifactorial problem.
Maybe just to add on this, because you just mentioned the different areas where diagnostic is done. I think when we want to take benefit, I think we have to standardize it. I think having a diagnostic for the clinic, which is independent from the wastewater, which is independent from the agriculture, will not help. I think we need a unified pipeline for diagnostics independent from the area where we are working, and this could feed into this database, which I was talking about in the future, and this will increase the amount of data being in this database exponentially at a certain time point. So I really think we have to go in a direction where we can really define these standards independent from the area, because what happens is exactly what you say at the moment. There are people in wastewater treatment plants who try to develop standards, and these are totally independent from the standards in the clinics. So at the end, you get two data sets and you cannot merge them. So I think this is a really very big problem that we should try to merge and unify the data sets that we get out.
That's a very good point. I'm happy to continue this conversation with you afterwards. Now back to this very important point of again, like AMR, develop incentives. I want to focus a question to Rohit Malpani and to Ganchi on the fact that, I mean, where's the gap in the final like delivery of antimicrobials? We have like from the first phase in investing into discovery, identifying possible candidates, to the final, development and approval and delivery into markets and introduction in a certain pace. Where are the gaps in your view? Of course, you are also focused in different areas, but if you could do the whole cycle, what is the gap between discovery to development that innovative incentive structures could tackle to develop new antimicrobials? Let's start with Ganchi.
I think what we see is a massive market failure and then just not enough capital being put into this. So the biggest gap is the money and stumping up the money, and who's going to stump up the money and where is it going to come from, and people putting up the money for their fair share. And I think that money needs to be distributed across the whole pipeline at the beginning with push funding and with pull funding, really. And at the moment in the EU, discussion is being had about a voucher scheme, and we've done some analysis on the voucher scheme, and we probably need €1 billion per product, basically. And this voucher scheme is somewhere between €150 million to €400 million worth of incentive, and that's just for the EU's fair share alone. So everybody knows this is a problem. This is a problem we've been talking about for the past 20 years. Like Nobel Prize winning economists have written papers on this. We know what the solutions are. It's at this point, the gap is the political will to stump up the money to fix this thing. And often it gets watered down through time. And health isn't a priority at the moment. Defense seems to be a priority at the moment, or national security and onshoring production. So I think just having the will, and hopefully within the next budget for the MFF, which is the EU spending budget, we'll be able to have, we'll really be pushing to carve out that amount of money, because this is a really solvable problem. And all the other stuff that comes along, the stewardship, the surveillance, that's all really difficult as well. But this feels quite simple to me as someone who's not been working on it for very long, but having listened to all these guys. And I'd be really interested to hear what Rohit thinks about whether this is the key issue and what are the other issues on top of that.
Yeah, so just to jump in, I mean, I of course wouldn't disagree that funding is a major constraint, but I feel there's a certain stubbornness here because, frankly, having listened and participated in these discussions since 2013, I suppose, that would probably be along the lines of what people were saying then, that we just simply need to inject enough funding into the pipeline in order to address these gaps and to ensure that the market works well. And what we know that since then is, of course, in certain areas such as for cancer, we now have a very healthy pipeline and of course, just really significant returns. And then also in other areas such as non-communicable diseases, such as for obesity, again, like just a very large pipeline and of course, a shrinking pipeline for infectious diseases and for antibiotics. So what I worry about is that if we just continue to only beat the drum on funding, that we're not going to necessarily deal with what has now become a really serious deficit. And people have seen the latest WHO report, which continues to illustrate that just how meager the current pipeline is, all the way from the start to the finish. And so I think there's just some nuance that we'd want to introduce into that. So one already I mentioned is again that we have to think really carefully about the types of companies that we are trying to invest in. And again, there I think it's this recognition that if we take the role in 2013 or 2015 and we take the role today, that pharmaceutical research and development is just not a function only of the United States and Europe anymore, that we are seeing a large number of companies starting to emerge in India, of course in China, and even in countries such as Brazil and South Africa and elsewhere. And so we have to really think more broadly about where we're going to develop new antibiotics, and especially I think from countries that are facing this sort of coalface of this problem and therefore also have industry and government that wants to address it. I think we also have to sort of not lower our ambitions, but also realize that there again may be low-hanging fruit. I think one of the things that gets ignored in all the discussion of funding and innovation is that actually, there's a lot of opportunity in recycling and repurposing and combining of antibiotics that, frankly, as we saw also in COVID-19 and other areas, have a much quicker sort of path from development to approval and to being used. And, the safety profile, obviously, for a lot of these treatments is already well established. And the cost of research and development and the opportunity to be able to really address some serious problems we think is possible. And again, the example for GARDP of putting funding into taking 3 old antibiotics and examining new combinations of those antibiotics to address neonatal sepsis is a good example of that. I think there's also a little bit of a need to sort of be clear between push and pull funding. There's a belief that just simply, again, writing large checks through pull incentives will solve the problem. And, the numbers grow from, let's say, $100 million a decade ago to now $1 billion and potentially more. And again, it is really important to have pull incentives. So for the companies that are developing antibiotics and are trying to bring them to market and to be financially sustainable, that we create those opportunities. But we should not be confusing that with trying to get larger companies that will never see a sort of commercial bargain to re-enter the market, and also recognizing that push funding at all stages of research and development gives us the flexibility and the opportunity to be able to plug a lot of these gaps that we see emerging for those companies that are developing antibiotics. And to add to that, it's also that the biggest gap from our perspective is one of equity. So we can develop new antibiotics, but we're not going to get access to those antibiotics where they're required. We're not necessarily going to test them in the populations that actually require access to those antibiotics. And we're not going to develop new antibiotics for children and babies or to label them for children and babies unless we have push funding for it, because it's just not going to be commercially interesting. And that means that, for children who are 1 out of every 5 deaths due to AMR, basically resistance will set in before we actually are able to label or develop a formulation that's appropriate for children. And none of those failures, which I think are not market failures, but are public health failures, are going to be solved through conditions on pull funding. It's too much of a blunt instrument, and it doesn't get to the heart of the problem. You're only going to be able to do that by delivering partnerships and providing push funding, whether to companies or indirectly through not-for-profit partnerships or through clinical trial networks to be able to address those problems. So it's not just about restarting the market, it's about the equity of the market, and it's about seeing a broader set of both developers and solutions to be able to really address this problem.
If you can answer like in really 10 seconds, if you had like $1 billion US today, and there was a huge AMR crisis coming with 50 million people dying a year, where would you put this 1 billion today? Would it be in developing a new compound, or would it be in choosing some key compounds and trying to develop and get approval? Rashid, Rohit.
I think that's kind of a false dichotomy, because I think part of what we're trying to do is think about, okay, let's take mRNA technology, not to avoid your question. What did it take to develop mRNA technology? It took 4 decades of government investment to actually be able to build a technology and all of the early scientific discovery and development so that companies could eventually commercialize that technology. And that's what we're potentially missing here. Resistance is eternal, and the need to address this is eternal. So we have to be able to build the basic foundations and framework to be able to invest in antibiotic development, both through public sector development, and we know that we don't have the scientists now. They're still continuing to exit the field, and that's probably accelerating given all of the funding cutbacks and reductions in force that we're seeing in certain countries. And then we need to be able to create a healthy ecosystem of developers. So the answer to that to me is if we had $1 billion, we need to, I think as Anand was saying, we need to make sure that we're really sort of distributing this very broadly, because this isn't just going to be about developing one antibiotic for, when you have multiple needs in multiple countries. We really have to think about this as long-term investments over a long period of time. And the dynamic of a $1 billion investment is it's only going to go to those who ultimately pay for it, which is high-income countries. Sorry, not a 10-second response.
Yes, a little bit extended, but yeah. Thank you. Someone of the panel would like to address those?
Yeah, so thanks so much. I just wanted to add a special on the issue of equitable access. And I think one of the conversation has been on the push funding, trying to see on how innovators are being incentivized to come with the new antibiotics. And I think there's a good initiative with, for example, GAP and Carbex. But one of the challenge that has been highlighted, it's keeping these developers and pharmaceutical companies, for example, existing in the market. And there is already good statistics regarding the financial distress and the cumulative loss that are leading to market failure and are leading to these companies to exit the market. So I think there might be also a more shift on pull incentives to see on how these developers and pharmaceutical companies are existing in the market. And that has a significant impact when it comes to equitable access of antibiotics. And we already had lessons when it comes to vaccines, for example. So if we might not address this with an equity lens, we might be able to develop new antibiotics, but then the access issue would remain a challenge. And I think this is where now it comes to these big farmers and big developers to work closely with small developers to build the capacity and ensure that they're having resources to keep existing into the market, and then we avoid the fragmented market and we avoid issues around market failure that would really manipulate equitable access.
Very much. Now I would like to open the floor to the public, online and in person. So please feel free to post any questions you have online, and now's the time for people here in the room to ask questions if you have any. I'm also following here online if you have any. Maybe we can give a mic.
One question about the involvement also of the people, bottom-up solutions. As quite rightly say, this is a continued challenge that we need a continued solution for. So continuing to develop new drugs to pour them into a broken use case is either lunacy or at least it's a huge ambition. So addressing more about the bottom-up and involvement of the public, mechanisms to perhaps not develop new drugs, but new educational concepts, new designs that involve the people as part of the solution, to get fewer of them to use it. I'm not talking about the doctors, I'm talking about the people at home that would use other mechanisms. They would use hand washing, they would use cleaning, they would use different design of their cities, they would use so on. How can we also incentivize that part of a non-pharmaceutical solution for a pharmaceutical problem?
I think at the moment the chances are really very good because people learned from COVID that staying at home for months, not doing any exercise is pretty bad because you get a lot of infections afterwards. And I think what we learned from animals, the same is true for humans. If you have no contact to nature, if you do not exercise, your immune system goes down and this increases the likelihood for infections. I think this is very easy. And this, I think everybody has realized now after COVID-19 that this is really an issue. So we have to motivate people more to not forget about this and to bring this into the daily life. On the other hand, I think now we are in Berlin, but there are even cities which are worse in terms of urban greening, in terms of urban infrastructure, in terms of getting nature back to cities, where people get the contact with biodiversity, which increases then also their personal diversity and their microbiome and all these things which protect from infections. I think this is also something which is very important to reduce the likelihood for infections. And as said, we can learn a lot of things from what has been done in the last years in farming, where the problems occur. I think this is very similar for humans, and the mitigations are also very similar to what we have seen in the agricultural side.
Or learning to live like animals.
At least doing exercise.
Any other questions from the public? Yes. Go ahead. Maybe give a mic to her.
I'll try and keep it brief. We're also running out of time here. But I was curious for you, Eric, just to hear, we heard a little bit more about the organizations from all of our other discussants today, but I wanted to hear a little bit more about how your organization, what it is that you're doing, and you mentioned behavior change, so how you're using behavior change to decrease rates of AMR within the communities that you're active in. And then I also had a question for you, Wenda, as well, is I think 4PAWS is important to include in this conversation about animals and the wider One Health perspective. You did say you had a few more examples related to that and how including animals in the conversation has been useful for combating AMR. I'd be curious either to hear that or, for the sake of time as well, just a brief recap on how it is that we have to include animals in these conversations.
Of course. So to the couple of examples, and thank you so much for the question. They were actually concrete examples of measures that were taken in various countries which have led to a reduction in antimicrobial use. And I think, so I did mention the pig example, which is probably the best known example in this case. But also we have, there are studies on how reducing stocking densities in pig farms in Japan has reduced the use of antimicrobials directly, and how rearing of calves on pasture instead of closed off environments only has reduced respiratory and gastrointestinal diseases in Switzerland, and also, of course, the use of antimicrobials. In terms of examples as to, and also to what you asked about more on what we're doing to include animals in this conversation. So beyond just chatting in very entertaining panels, we are actually working together with key institutional stakeholders, with the Food and Agriculture Organization of the UN. We are engaging with the World Organization for Animal Health. We are engaging with intergovernmental organizations, working together to integrate animal welfare concretely into AMR policies that are then being implemented, whether we're talking about trainings or broader policies at a global level, such as the Global Action Plan on Antimicrobial Resistance. I think am I already at the end of my time? Am I right? I don't mean to. I will just summarize. So I hope this answers your question. Happy to share more details afterwards.
Maybe I mean, to the short time, we have to close the event. We can continue the conversation here over morning breakfast. And I would like to thank everyone for being here with us today. So now I would like to present my closing remarks and the call to action. So we have here 5 points on the screen summarizing the call to action for today's event. So today's conversation has underscored that no single actor and no single investment can solve the AMR crisis alone. So the solutions should be done uniting governments, donors, private sector, and civil society around shared incentives, shared accountability, and shared action. So that being said, our call to action is clear. First, recognize the global AMR crisis. I think it's quite clear. Number 2, address broken innovation systems. Market failures have stalled antibiotic discovery. Renewed investment and redesigned incentives are essential for new discovery of new antimicrobials. Adopt sustainable funding and policy models. So governments and partners must commit to performance-tied, de-link funding mechanisms, expand EU-level R&D investments, and so on. So number 4, strengthen prevention and stewardship systems. I think some of our speakers were very vocal on it today. Reinforce infection prevention and control, water sanitation and hygiene, and antimicrobial stewardship programs to reduce resistant drivers and preserve existing treatments. And last but not least, unite through Global Coalition for Equity. So join the Infectious Disease Alliance call to action to embed One Health principles, build across sectors, and to ensure innovation, access, and stewardship around AMR. So please feel free to sign the call to action through the QR code being showed here on the screen. And together we can really build a world where antimicrobial innovation thrives, where access is equitable and the promise of modern medicine is preserved for generations to come. So thank you for coming for this event today. The link will be posted on social media and our websites to be shared largely. And thanks, and feel free to join us for a little coffee around there. Thank you.